Hello? I wonder this one. Doesn't really allow me to change the screen. That's kind of weird. Hmm. Alright, alright. Alright, hey guys. Just doing some flashcards. Alright, let's just go send that in. Cool. Alright, let's, kind of weird. I don't know why that's my name. Alright, let's change that. Yeah, you know, it's okay. Let's just go. Let's go into it. So, name the type of pleural effusion developed from like an imbalanced hydrostatic force, increased capillary permeability. So, I don't know why transitate is like imbalanced hydrostatic. And exudates is like increased capillary permeability. So you have the capillary stain. That makes sense. Here you have like hydrostatic forces. Okay, that kind of makes sense. Mechanism by which these types of pleural effusions develop. Transitive, I think we know this. Increased hydrostatic or imbalanced hydrostatic. This is like impaired capillary permeability or increased in that. That's kind of cool. That's kind of cool. All right, so we got one shad rate. I hope it's not much, but hey, listen. In exudative pleural effusions, increased capillary permeability allows what two things to leak into the pleural space? Capillary permeability allows what two things? If you have like exudative, bro, it's like protein. Proteins and you got cells. Okay, fuck that. What is the Light's criteria used for? I mean, it's used for telling which is transitive, which is exudative. Hey. That's cool. Three components. One is LDH, of course. One is. What is the other one? I think it's protein. And the other one is just the ratio of the LDH. And that's what it is. So you have you have pleural fluid LDH and protein to a serum protein LDH. So LDH one. Let's see. LDH one is 6, I think. Yeah, and then you have a 0.5 for that protein. Another one's just, I think, 2/3. You just have to kind of remember that, bro. You just have to. You just have to. All right. So that was kind of cool. Color of the transitive one. The WBCs, the RBCs, the pH, the glucose. Let's go. Let's go. So, color is kind of straw. They don't talk about anything else. WBC they don't talk about. RBC you don't see any. pH I don't see anything there. Glucose kind of seems normal. Hey, you know how to. Common cause of transitive one. We're talking about some TBs maybe. The TB, the heart failure. We can call it TB also. Come on. We can go with TB as well. Okay, heart failure. We're just gonna go with heart failure. What are the causes of transitive plural? I think we know one is heart failure. It could be again TB. No, they don't love it. They don't love that TB stuff. Okay, so heart failure. You got the cirrhosis. You got Oh no, that's nephrotic. That's nephrotic. Then you got liver. Okay, so you have heart failure. You have your what did it say? Nephrotic and cirrhosis. You just have to remember those three. Those three images. All right. I hope it looks good. I hope it's not too bad. Oh, you gotta put it in the center. Maybe that'll work. So additional findings in heart failure patients with this. So lung physiology, I think it's effective. Physical exam. Oh wait, I think lung is pathology. What? It's just I don't know. Lab findings in pleural fusion. I don't really remember. You have pulmonary edema, physical exam finding. You have a JVD. Hey, JVD. There you go. And lab findings. I think you find an increase in BNP because of heart failure. So you kind of get if it's transitive or exudative. From that, you have to base it off of the stuff. So okay, heart failure means by BNP is increased. I think that kind of makes sense. What is the mechanism by which nephrotin produces transitive pleural effusion? I think it's because of the albumin. So we're gonna go with no albumin. So yeah, that's what you get. That's really what you just get. It's super weird. Pleural effusion due to cirrhosis. What is that called? I don't know. Hepatic hydrothorax? I don't know. Actually, that's not really true. Oh, wait, I'm actually right. It is called hepatic hydrothorax. It's right side. You're right. Right side, and it's kind of unilateral. Hey, we're going there. We're going. All right. How does it lead to pleural cirrhosis? Didn't I just do this? Did I just do this? Ascites allows. Yeah, that's how it happens. What? All right. Some 3 physical exam findings in patients with like pleural effusion due to like cirrhosis. I don't know. 3 physical exam findings in patients with pleural effusion cirrhosis. I mean, you will have like cirrhosis, some like maybe enlarged liver. You could have some jaundice. Maybe you could have asterixis. So you have asterixis. You have jaundice. Yeah, spider angioma. So you have like the cirrhotic feature. That's really just what you have to remember. I can't pronounce nothing. But what is the most common cause of exudative? Exudative has malignancy? No, it's pneumonia. All right. Pneumonia, fine. All right. Exudative pleural effusion, 12 causes. There's 12 causes of exudative. So we saw pneumonia, obviously malignancy, TB, pancreatitis. It's a shout, but yeah, it's not that big of a shout. Lymphomas, I don't know. I don't know the time. I got 5. You got pneumonia. What is this? Flame hell. Okay, we get the pneumonia. It's parapneumonic effusion. Do you have that? Flame helmet fetter. So that's called parapneumonic. Kind of para to the pneumonia. Parallel to the pneumonia. Look at that. Parallel to pneumonia. Okay, cool. We got TB. I was kind of right with TB. Yeah, I kept going with TB. So that is apparently exudative. Yeah, just have to. You kind of have to remember that. Hey. Malignancy. I was right about malignancy. We do have the crab. You got TB. You have parapneumonic effusion. You have malignant parrot right here. Pirate. I can't pronounce. Pulmonary emboli. That's kind of cool. What else do you have? You have your joints. You got your rheumatoid arthritis. You have to remember that. Rheumatoid arthritis. And you got SL of E. I think you got SLE. Where you at? Where's that? You got the wolf. You got the wolf, bro. You got the wolf. You got the rheumatoid. And you got some lemons. Whatever the lemons are for. You got a cannonball. What the hell does that mean? Abdominal abscess. That could be anything. What the hell? It could be hepatic. Abdominal abscess. Is that okay? They actually did that. They really did that. Esophageal rupture. Where did I see that? There's so many things to remember. But there's a lot of. It's cool that you can remember these images. Okay, there you go. Esophageal rupture. You got your favorite pancreatitis. You got some blood, hemothorax. What else you got? Chylothorax. Oh, this guy right here. He's getting beat up by the malignant guy, the crab guy. This guy. All right. Yeah, hemothorax. You had pancreatitis. You had your favorite TB. You had everyone's favorite TB. I just said that. What did I just say? I keep forgetting. Esophageal rupture. What else we have? What else? Chylothorax. We have what else? Parapneumonic effusion. We got what else did I miss? A lot. Rheumatoid wolf. We got the SLE rheumatoid, the SLE. Pulmonary emboli. Forgot about that guy. Abdominal abscess. That's gonna be. I probably will not remember you. All right, let's move to the next one. Okay, parapneumonic effusion. We have to know the 3 symptoms, the 1 lab finding. Yeah, this will be okay. So what do we have? We got someone with fever. We got some cough. Don't mind me yawning. Yeah, I'm kind of bored. Yeah, heck yeah. Fever. We got some cough. We got the sputum. Where's the sputum? Oh yeah, you can see sputum, bro. You can see the green stuff. Sputum. We got some fever, cough, sputum, and will have a new WBC. So it's fever, cough, sputum. I kind of get it. It's for any respiratory, but WBCs. Hey. That's important. Uncomplicated. What is in the analysis? WBCs of course, neutrophil. Whoa. Wow, that yawn was way too big. Damn. I'm getting sleepy. Damn. Alright, neutrophil. That's a normal pH. Well, we don't know that. Normal glucose. Well, we don't know that. Bacterial invasion of pleural space. A condition. Bacterial invasion. TB. No, apparently that's complicated. Complicated just means, hey, got the bacteria going in, bro. You got them going in. Purple for gram stain, maybe. Could be a shout. What are we looking at? Pleural fluid analysis, complicated. What we got? We got some WBCs. We got some positive gram stains because he's purple. Glucose less than 60. Well, you can see the falling glucose. All the candies are falling down. Glucose less than 60. You got some lemons falling down, so you got some pH going down, basically 7.2. Wow, very interesting. So you got some glucose, you got some positive gram stains, and you got some pH. That's complicated. So if you just have WBC, not complicated. If you have other stuff that you talked about, hypoglycemia, you talked about low pH. We talked about the gram stains positive. Okay, that's kind of cool. Signs and symptoms, TB. We kind of notice fever, eating rise of temperature, cough. We have optimism, weight loss. Hey, name it. All right. We notice pleural fluid analysis of TB. Could you have WBCs? You will have WBCs. You will have a lot of meat. A lot of meat there. A lot of meat. So you got some protein. You got your. Do you have your LDH? You got some milk. You got some milk, yo. You got some milk. You got protein. You have WBCs. Where is the WBCs? I can't find it. Am I missing? Oh, these are the WBCs. Never mind. AFB culture smeared. Where's AFB? Okay. Purple. I'm gonna yawn like once in like 2 minutes, so don't be too mad. Armada. ADA. Haha, nice. So what did I read? WBCs. You got your proteins, you got your milk, you have your. What do you have? You have your AFB. Yeah, you got that. And you got your ADA. You have to have ADA. It's impossible to have ADA. Wow, I literally have no one. Kind of cool. Okay, that is super cool. But listen, hey, we're here to grind. We're here to grind those people. Okay, fungal cause like pneumonia. I wonder if I have like something on the thing. I don't know if I have like maybe something here. It could be a trap, but I don't know what else. Here's some tags, but fungal causes of pneumonia. What are some of the fungal causes? Okay. Fungal. Looking at histoplasmosis, cocci, blastomycosis. Hey. Okay, so some 3 ways malignant pleural effusion kind of develops. What are the 3 ways? So we have 3 ways. I don't know. So we have your hematogenous. We got your lymphatic, who gives a crap. Demographic of the malignant pleural effusion. So we have some old guy. We got a smoker. Old and smoker. Pleural fluid analysis of malignant pleural effusion. Okay. What do we have? RBCs. What else? Lymphocytes. Hey, this is a group. What else do you have? Malignant cells. You got some cells there. You got some cells. Okay. Some cells there. Cool. How do we diagnose this? Biopsy? I don't know. Okay. Just go with pleural fluid cytology. Really. That's really what we do. Mechanism for the pulmonary emboli that can cause this pleural effusion. Okay. What is the absolute mechanism for this? For the pulmonary emboli? Because there's like obstruction of blood flow. It's an infarct there. You see an infarct. You see that black thing right there? Infarct, bro. Alright. Symptoms of pulmonary embolism, yeah, you will have your same symptoms. Vital signs, tachypnea, tachycardia, associated conditions, as lower extreme DVT. Hey, it's the same stuff. So pleural fluid analysis of, let's say, an autoimmune disease. What are you looking at? Looking at when they mean autoimmune, they mean rheumatoid SLE. So yeah, pH is kind of decreased. Yeah, okay. Glucose is it's falling. Lymphocyte predominance, again, you got a lymphocyte guy. So you got those in the way. That's cool. Pleural fluid analysis in, let's say, rheumatoid arthritis compared to SLE. It's similar but not as extreme. Well, whatever, we can't really do that. Name 2 scoring symptoms for pneumonia. That can sort of stratify the patients by mortality risk. So we're looking at pneumonia severity kind of index. And your favorite. Everyone. So it's PSI. Everyone loves PSI. You know, I like PSI, pneumonia severity index. And we also have curb. Curb 65. It's important to know these. Okay, it's important to know where does pleural effusion develop. So it's usually left side. Why is that? The guy's on the left side. There's a rupture, but listen, the guy's on the left side. Is he on the right? No, he's on the left. This could be. Is this a girl? No, actually, no. That's probably a girl. Never mind. Or whatever. Left side of the fusion. Hey, it is what it is. It is what it is. Now, rupture symptoms. You will have pain. I think you'll have pain. Yeah, you'll have pain. Let us know. What am I missing in rupture? Dysphagia. A vital sign. Lab finding. Fever. You got fever again. You got some WBCs. You got severe sharp chest pain. Chest pain. Most common cause of an esophageal rupture is iatrogenic. Really? You're putting an endoscope in and it injures it. Wow. That is dangerous. Especially that is probably one of the things I might have to be careful with. Then again, I probably will not be dealing with endoscopes as an intern. Probably someone more experienced will deal with it. Yeah, but like in the you know what I was going to say something. Never mind. Pleural fluid analysis of esophageal rupture. Normal. Nothing really spectacular. I'm assuming. Okay, never mind. They had the low pH. At a low pH, you got a low glucose. Amylase, for some random reason, is the dog's salivating. So you got a high amylase. You guys have some maybe make an undigested food because there is some food from there going. That would be weird if you get undigested food. That would be weird. That would be insane. Okay. Looking at the prognosis. All right, prognosis of a pancreatitis. Like pleural effusion. Damn, I got no. You is not responding. What do you mean not responding? Open the studio. Let's open studio, bro. We're gonna open the studio. We're gonna find out what's going on. What's going on, bro? What the fricky? What the fricky? Okay, close that. Commended. Oh, now it's good. For some reason, now it's good. Okay. That's kind of cool. Okay. So we're back. Hey. Want to see something cool? Whoa. Dude. Whoa. Okay. So what if I just like put some like stuff on? Okay, can I just like move this away? Okay, let's go. I am streaming this right now, and no live viewers. It's amazing, bro. Can I like flashcard myself? Default overlay. Yeah, that kind of looks cool. Okay. That is cool now. Let's go back to the dash. Let's manage, bro. Let's manage. What are we up to? What are we bees up to, bro? Stream held. This is at an all-time low. It's at an all-time low, bro. Closed captions. Okay, whatever. I'm getting way too. This is my first time. Whatever. Pancreatitis with a pleural effusion is kind of poor. The poor outcome. That is sad. Chief complaints: pancreatitis. What is the chief complaints of pancreatitis? Pain, obviously, radiating to the back. You will have pain is usually a consistent finding. Anorexia, you'll have some nausea, vomiting, that kind of stuff. But yeah, mostly that's the main one. That's the main one, bro. Pleural fluid analysis. So we're looking at pancreatitis. What do you get? Some amylase, maybe some lactate. I don't know. That's okay. So amylase. I was kind of right. I was right. I'm always right. Hemothorax. Well, I'm sure you'll get blood. Yeah. So serum hematocrit, kind of more than 50 for that. Wow, so the pleural to the serum, more than 50. Pleural to the serum. Damn. Alright, excuse me, burping. What's the most common cause of a hemothorax? It has to be injury, trauma, something, and an aortic rupture, fine, whatever. Chylothorax, what can cause a chylothorax? A chylothorax? Come on, esophageal carcinoma? Well, some carcinoma and thoracic surgery. We got the carcinoma and we got the thorax. Yo, we got the surgeries. Alright. Wow. I am on a different mission. Okay. Alright. So, pleural fluid analysis is kind of there. Chylothorax. What are you looking at? Milky. Yeah, whatever, bro. Whatever, bro. Milky, it's, you got some TG. You got some TG triglycerides. Milky. That is very cool. Now, obstructive lung disease. There is irreversible airway dilation. Chronic inflammation with irreversible airway dilation. I'm not sure. Irreversible. Oh wait, we CO of PD. Never mind. It's your favorite. It's your boy. It's the bronchi. The bronchiectasis. Okay. Kind of weird. Alright, so we're gonna move on. The PSI. How do you score? I don't know, with direct or outpatient. I don't know. 1 to 3, 1, 2. 1, 2 is what? Outpatient. 2, 3, or just 3. Inpatient, 4, or outpatient. Depends. It's somewhere between. 4 or 5, yeah, that's inpatient. Never mind. Yeah, don't even consider. That's PS of I. Some chief cleans bronchitis as well. We kind of noticed. There's dyspnea, cup full of sputum mucus. I mean, we kind of notice. Okay. Damn, I am on some sleep train. Alright. This is a little weird one. I'm gonna have to stop the stream and go to sleep.